This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best.
Hello and welcome to the Nupsala Podcast, where we're recording from the Veterinary Osteoarthritis Alliance conference down at Loughborough. We've taken over a space just for podcasting, and I've been stealing some time with the wonderful speakers that are here over the next couple of days. So in this episode, we're going to look closer at one of the biggest questions in managing canine joint disease, which is when is surgery the right path, and when might orthobiologics be more of a meaningful alternative? So I'm delighted to be joined here today by Dr. James Guthrie. He's a senior orthopaedic surgeon at Fitzpatrick Referrals. He's a specialist in both small animal surgery and canine sports medicine and rehabilitation. And he's here to help us unpack those decisions that make in practice and what clinicians should be thinking about in the field as it evolves. So thank you for joining us today, James. So we're going to talk about the management of joint disease, but what are we specifically kind of talking about as that umbrella term? What are the conditions that you manage mostly with this?
In terms of joint disease, I suppose that is a very broad phrase. It can mean many things. So it can start from the subtle, the minor, when things are starting, right through to becoming a real severe problem. And I guess in terms of when we as vets see the patients, each patient may be at a different stage on that journey. And I think it's a key thing to sometimes identify where they're at, because there may be different things that we can do. So in terms of the cases that I guess I normally see, and I'm sure many vets tend to see, it tends to be elbows, hips and stifles. They're the sort of top three main sort of culprits of joints that get problems. And part of the reason that these joints get problems is because often the joints don't move as they should do. They don't fit together so well, or they move in abnormal ways. And this then leads to the start of causing inflammation, wearing of cartilage in the process of arthritis. So that's often our starting point. And I suppose depending on where we're at can depend on what our options are. So hopefully we can try to run through some scenarios and unbox some of these options.
So when a patient walks through the door, what's your decision-making process, and where do you start with identifying what the problem is?
So I guess the starting point is usually the history, asking questions, what's been happening, and we can gather so much detail from what owners describe. For me, I guess I generally know beforehand the patient is coming to see me because they're referred from the primary care vet, so I can often have a little look through the notes that the vet has sent me. And what I'll frequently do is actually send a little questionnaire to the family as well, so they can fill out some answers. And I've sort of created the questions myself, the things I would normally ask in the consult, but they can send me some information. And probably 9 times out of 10, before they've even walked through the door, I know what's wrong based on how they answer these questions, because some things can be very common. So starting off with the history is really useful. That can help narrow things down. From there, it's then really useful to look at the patients, see how they walk, see how they move. So I'll maybe watch them walk up and down outside, but also in the consult room, let them off the lead, let them wander around, and as I'm having a discussion with the owner and taking the history, it's a chance to just keep an eye, what is the dog doing? Particularly things like sitting and then getting back up again, we can see how they do this. And many dogs, the lameness can be intermittent, so it's not always present when they come and see you at the consult. So for me, I always ask owners to get some videos as well and can send those through, and that can be really helpful.
So can you just talk us through maybe a specific case that you have dealt with recently where you were faced with that decision of surgery or orthobiologics, what that case was and how you came to that decision of your treatment option?
Yeah, I think the way that I tend to look at it is what is the risk and what is the reward. Many surgeries that we do in orthopedics can be quite routine, can be quite low risk, but they always come with a risk. And then there's other surgeries that we do that have a greater risk associated with them. Risk of complications, risk of prolonged recovery, and other things that maybe don't always go plain sailing. And therefore it's kind of weighing up that risk and reward. So let's take, for example, a patient who has hip dysplasia and the beginnings of osteoarthritis secondary to that. Now, if that patient's clinical signs are quite mild, so their lameness is infrequent, there's this odd bit of stiffness now and again, they're generally leading a relatively normal life, then that's perhaps a case where it might be a bit of a leap to do a hip replacement. Hip replacements becoming quite routine, we do them every day, complication rates are coming down, but it's still a big intervention. So perhaps in that patient, that's whereby maybe intervening with orthobiologics may be a helpful step. For me, I quite like joint injections as a treatment option because it doesn't then have a systemic effect on the patient. So if we can perhaps hold off giving them systemic medications, then I think that can be beneficial, particularly in young dogs. And we know that their joints are going to get worse. They're going to need medication later on. So if we can maybe keep that in our back pocket, hold off for a little while, try something else first, then that might be a scenario. But then in many other cases, let's just take, for example, the stifle and cruciate disease. So when that cranial cruciate ligament ruptures, the stifle becomes unstable. It's moving in an abnormal way. It's this dynamic problem that's causing the pain, the lameness, leading to the progression of arthritis. So if we were to think about injecting that joint, it may make the joint a little bit more comfortable by reducing inflammation, reducing pain, but the joint is still unstable. It's not sort of treating that underlying problem. So in that case, I would be thinking about surgery first, and I would choose surgery, such as a TPLO over an orthobiologic. If that joint then starts to progress, that stifle is becoming more affected with arthritis, then I might start to think, okay, the next step up from surgery is a knee replacement, which again is maybe quite a leap. So we need to then decide, can we think about something else? So before that surgery, a knee replacement, I may try orthobiologics first and see if we can use that as part of a multimodal approach. And if that's not failing, then we can kind of go to the next step up in a surgical procedure. So trying to sort of weigh up that kind of risk and reward, how bad the patient is at that time as to what we do.
We're talking about orthobiologics there again. That's a really broad term. What would you opt for? And are you opting for a regenerative medicine, or are you opting for a kind of non-systemic anti-inflammatory approach?
Yeah, so I typically tend to, I give owners a lot of information actually and go through a lot of detail with them. I try to give them all the options. And this is the key thing. I try to give them all the options all the time and try to help them make a decision what's best for their dog. There are certain scenarios where I'd recommend one option over the other, but I give them the option. And some people say, oh, I had a steroid injection for my shoulder. It really helped me. I'd like my dog to have the same. Some people like the idea perhaps of a more regenerative approach, the body helping itself. So I kind of give them the option. In terms of, I guess, my decision making, I tend to use orthobiologics more often because I like the idea of things being a little bit gentler, kinder, using the body's own natural systems in order to help itself. The times where I may opt for a steroid is usually either in a case where I know there's been a real sudden increase of inflammation. So we know they've got a little bit of arthritis, it's generally coping well, and they've suddenly jarred their joint. We can feel it's really effused, want something that can really perhaps settle that down. And it's kind of a one-off. It's not sort of going to be like a repetitive thing. I'd maybe try to avoid it in repetitive cases. The other times I may use a steroid is if I have some uncertainty and I'm not sure is that joint the problem or not, then you could use it as a diagnostic tool as well. You give the steroid injection into the joint and maybe within a week or so they improve, and then it might be that lasts for a while, or if the lameness comes back, then we can start to look at other approaches. And the other time, I guess, is if the joint is really badly affected, where we're running out of other options, we may use it then, but try to avoid it because there are some concerns of repeated steroid injections could induce some damage to the cartilage and tissue, so try to avoid it in that regard. So yeah, if I can, I'll try to use orthobiologics as an option. In terms of when to use stem cells versus PRP, the decision making for that, I guess, comes often down to sort of two factors. One is sometimes, is this going to be for an ongoing condition whereby there's not an urgency? So for example, maybe might be osteoarthritis. We know the patient's going to have it for life and it's not something where something is going to dramatically happen in the next few weeks. So we have time to extract some stem cells, process them in the lab, and the patient can come back a few weeks later. Whereas if we had, say, a soft tissue injury, a tendon injury, by the time we start to wait a few weeks, it may be that we could have already given something like PRP that's readily available. We can take it, process process and inject it all at the same time, and we can use that for that sort of quicker basis. So that's a time where I may elect to do PRP by itself. The other thing that comes into it as well is finances. I guess there is a bit of a difference between the two in terms of the cost because of the lab sort of processing. So for some clients, that's a deciding factor as well.
I know we might have touched on this a little bit already, but is your decision making different for the kind of younger patient versus the older patient?
Yeah, so I guess it doesn't change hugely in so much as, I guess generally for the younger patients I would try to go for something more natural, as we sort of touched on, but we can still use them in older patients. We ran a study where we looked at the platelets and various different factors within the blood for patients of different ages, different signal months, and we found that the sort of platelets and what could be used for PRP was equally as good in older dogs versus younger dogs. So there wasn't this huge difference in the study that we ran. So we can still consider it for older patients. I guess the correlation with age is usually disease severity. So older patients usually have more severely affected joints. And sometimes with those dogs, the improvement that we get from the orthobiologic may be less dramatic to the family or to us when we're assessing how they are doing. Part of that is because often these arthritic joints are mechanically not normal. There's usually sort of collapse of the joints, and there's a lot of thickening around the joint, there's a reduction in range of movement, patients are compensating from tight muscles, so there's going to be a mechanical component to the lameness in a lot of these. If we think about perhaps our patient with elbow arthritis, we have these dogs where they're abducted and circumducting their limb, so that's always going to happen no matter what injection we give. So there is some limit in terms of what they can achieve in those patients. But it may be that if we give a steroid, perhaps the improvement is seen a bit quicker. Sometimes for the family of the dog, that can be easier for them to appreciate there's a difference. So sometimes as well, if they're a bit unsure about to go down the route of injections, we could perhaps do that as a starting point. They may then see, oh yeah, this has helped, and it's easier to see the improvement because it's usually a lot quicker within a week or so. Unfortunately, they do tend to wear off more quickly is what I have found. So if we want a more sustained improvement, that's also the way the orthobiologics I find are more helpful.
So what kind of duration of action, or is this a silly question to ask, but what binding with the orthobiology? I mean, say your response for PRP, for example.
Yeah, so it depends a little bit on how severely affected the joint is. Even then, there's a lot of variability between different conditions and different dogs as well. And sometimes even the same dog with the same condition, the same joint, we do one injection and we see a response, and the next time we give it, the response is different. So there is a lot of variability. And I think for me, that's a big frustration because I'd like to be able to give people more information, be able to even predict which dogs may get a better response than others. So it does come down a little bit to trial and error for that individual dog just to see how it helps. Typically, I suppose, for most dogs, we're maybe performing repeat injections of sort of stem cells maybe once or twice a year. So it's maybe sort of 6 to 12 months is typically what we're doing. And again, that definitely correlates with how severely affected the joint is with arthritis. PRP by itself, I guess typically we tend to maybe see shorter durations, maybe sort of 3 months to 6 months, but again, that can also vary a lot. There's some dogs we give the injections and they seem to have almost no effect, or sometimes they have a great effect and then it's gone quite quickly. So there is a lot of variability, and that's a huge frustration in terms of predicting what's gonna happen. But
and that's orthobiologics through and through, really, isn't it? One of the challenges with it. So is there one area in particular that you prefer to use orthobiologics, or you've seen the best effects of one joint area that you feel is best served by orthobiologics?
The one we definitely use it for the most is the elbow, and I think partly because it is such a common joint to have a problem with, and because we don't have a perfect solution for the elbow. With elbow replacement, that's kind of a completely different kettle of fish. The outcomes are not as predictable as with hip replacement. So I think with the elbow, we're looking for alternative options and alternative approaches and trying to do things we can to manage those patients so hopefully they don't get to the stage whereby we're needing to consider such sort of procedures. So they're definitely the common one that we tend to see. So in terms of elbow patients, I do use a lot of surgery, but there's basically different stages and different different surgeries depending on where the joint is at. And this again is what I would tend to weigh up, is where the joint is, where the dog is, where the family are in their journey of the dog's condition and the joint's condition, to decide, do we take the jump to the next sort of surgery, or as a bit of a middle ground, do we consider using orthobiologics at that point? I do use a lot of orthobiologics in part because lots of people who come to see me are interested in finding out what their options are, and therefore we'll often do some diagnostics at the time, which generally means sedating the dog. And for any intra-articular injection, that's one of the biggest downsides, as I guess, is the patient does need to be sedated. But for us, it means they can come into the practice, we can have a conversation, we can do our exam, the dog can be admitted, it can have any sort of gait analysis, it can then be sedated, can go into imaging, so it can have CT, MRI, radiography, ultrasound, whatever it needs based on its condition. And then immediately we have our disposal different things that we can inject, so we can do that there at the time. So we can kind of do everything whilst the family are there for that one visit. And often people are traveling from all over the country to come to us. So sometimes them sort of, coming back and forth can be a bit more of a challenge. So if there are things that we can use whilst they're there, kind of run through a range of options. But for some people, if I give them the option of trying these tablets for a number of weeks or trying this injection, and if the tablets aren't so great, come back for the injection, many people feel, well, whilst I'm here, I'll maybe do the injection now. And particularly if the dog is being sedated, for some diagnostics as well at the same time. And then we can work out the sort of best option for them. So I use them a lot. And also, again, if I can keep the patients off systemic medication, not that I'm against medication anyway, and if patients need pain relief, they should have it, but it can be a way perhaps to mean they don't need it, or can have lower dosages, or perhaps less medication, so it can kind of all work together. So the one I guess that comes to mind probably the most, that we tend to use them very frequently in tandem, is for patients that have elbow dysplasia. And the process of elbow dysplasia, for those who aren't aware, all of the problems that happen on the medial side of the joint, so the inner side of the joint, and we have this friction, this rubbing and this wearing of cartilage on the medial side, whereas the lateral side is usually unaffected or less affected. So a procedure that we will consider for many patients is to try to change the mechanics and also try to improve the inflammation. So by changing the mechanics, we could take pressure and move it away from the medial compartment and transfer it to the lateral compartment. And that can be done with a sliding humeral osteotomy, or SHO. So this is whereby we cut the humeral bone and we change the angle of the humerus to change the way that weight is transferred through the elbow. The more pressure is shifted to the lateral side and the medial side is unloaded. The idea is sort of based on a human knee surgery, where if you have a unicompartmental knee problem, they can sort of cut your tibia, change the angle and try to take pressure off. So it's trying to reduce the friction on the inner side of the joint, which can then help reduce pain from the increased pressure on the cartilage and subchondral bone. And also by reducing the friction, we're hopefully going to sort of slow down further cartilage wear. But in terms of choosing this procedure, we definitely don't do it on every single dog. Though we're typically not doing it in dogs whereby, the cartilage is completely healthy and pristine on the medial side. It's dogs whereby there is already some cartilage wear. So we know that these dogs are going to still have some degree of ongoing inflammation within that joint. And therefore, these are ones where very frequently we'll follow up with orthobiologics as well. And it's quite handy from a logistics perspective, because the patient is in surgery for the SHO, and the stem cells that we use are usually adipose derived. So we take some fat tissue and we're going to extract the stem cells from the fat. So whilst they're in theatre, it's an ideal opportunity to take that fat tissue as well. And then we want to make sure that the bone heals okay before the dog returns back to normal activity. So we're going to take follow-up radiographs, which means we're going to sedate them. So they're going to come back at 6 weeks after surgery for some radiographs. They're sedated. It's then an ideal time to then inject the stem cells because they're already sedated. So we're not really sort of changing what was going to happen with that dog in regards to the number of procedures or the number of sedation episodes it was going to have. And then we typically see clinical improvements, but as time goes on, the years go by, we would expect some of the symptoms of arthritis to progress, and then we have the stem cells stored and can then use them again as part of an approach of trying to reduce inflammation and pain by continuing to use them.
Yeah, perfect. So for clinicians who are just trying to find their feet with orthobiologics, they're faced with patients that they know will eventually maybe need surgery, but they want to have some interim measure, is there any advice that you would give to people just starting out?
Yeah, so I guess probably the biggest challenge for many vets perhaps in getting into using orthobiologics is being able to put the needle in the joint. It's something that quite often many vets may not do or do infrequently. So being able to improve your ability to take samples of fluid from joints is really, really useful, because then you can be confident that what you are injecting is going where it needs to be. So start by making sure you sort of know your anatomy and knowing the sort of landmarks in order to get the needle in the right place. And it may be perhaps in other patients who come to see you for joint problems, they may be ones that you can start to hone your skills in taking joint fluid samples from. And where you take the joint fluid from is exactly where you inject orthobiologics as well. So you can start to learn these landmarks, learn these techniques. So by putting the needle in the joint, using a syringe to draw back that synovial fluid, that's a way to confirm your needle is in the joint. And I typically tend to do it by palpation. You could try to do it ultrasound guided. So if you were used to sort of guiding the ultrasound to take liver samples and things from the abdomen, perhaps you may find that a useful technique. But I guess being able to make sure you can get that needle in the joint. And for some patients, we're perhaps tending to think about those with arthritis, and those joints can become quite gnarly, and they're often harder ones to get the needle in. So again, it may be perhaps get comfortable with taking joint fluid samples, and then you can consider injecting the orthobiologics.
So looking ahead to your role at Fitzpatrick's and the work that you're doing there, is there anything that you're doing with your patients that might not be kind of in the mainstream yet, or you think that there's some approaches that you think that might come in handy for other clinicians?
Yeah, so I guess for us, we very much want to offer all patients all of the options all of the time. So we kind of want to give them that range of options. Therefore, we can try to choose what is best for our patient. So we have the options of surgery, orthobiologics, other medications, but also things like rehabilitation with physiotherapy, hydrotherapy, and a whole kind of holistic approach is how we try to look at things. Now, in terms of surgery, that is something whereby as time has gone on, different procedures are becoming more advanced and more available, and also becoming more routine with lower risks associated with them. So there are procedures of various different arthrodesis and various different joint replacements that perhaps historically weren't available that now are. And again, these can be fantastic options for many patients, because technically they are the only way to beat arthritis. By doing a joint replacement, we can beat it that way. But also what we want to do is, again, for some patients and for some families, that might not be the best option with surgery. So we kind of want to give them that sort of broad approach of also using orthobiologics as well, and any other intra-articular injection. And I guess what we're sort of generally finding as well is that maybe it's a combination of therapies into the joint, so kind of a combination of different injections, and often they can have a synergistic effect. So sometimes it's not a case of picking just stem cells or just PRP or just adding in a lubricant as well. But a trifecta of adding all those together is what we're sort of finding is sometimes giving us the most sort of prolonged and best kind of benefit. So that's maybe something else to sort of take away is having this kind of multimodal approach of different therapies at the same time. There's lots of options, and I think sometimes that's a bit overwhelming for vets and the family of, you know, dogs and cats to know which should I choose, because there are various things. There's not sort of the one holy grail that's the best thing, but things are definitely progressed with many more options than just NSAIDs and REST. So there's a lot more that can be done.
I can really see that, as I work a lot in the equine field, and we talk a lot about this sequential treatment, knowing what stage that joint is in and finding the solutions that fit that stage that the joint disease is in, and that might be combining therapies in this sequential fashion. And so I think that will probably cross over, and as you say, this kind of the trifecta of treatments that might just fit in together in a multimodal approach. Fantastic. Well, thank you very much for talking to us. I like to end our podcasts by asking guests what 3 things they would really like people to take away from this podcast, the essential bits.
Yeah. So I think the first thing I always suggest is, if you can, obtain a diagnosis. Don't just think it's a joint problem, it's OA. Try to get a diagnosis. I think that can really help in order to better predict prognosis, make sure it's not something else that's going on, and also gives people options if they know what is wrong with the joint, what's causing the problem. stage it's at. The second point, I guess I would suggest, I touched on it earlier, is to always give people sort of all of the options all of the time. And therefore, I do try to involve people in the decision-making process for their animal and try to sort of talk things through with them so that they're sort of on board, they're engaged, they're helping to make a decision that's going to be right. And then the other thing that I always tend to do when looking at any case is I sort of do this focused assessment and then sort of zoom out. So look at what is best for that individual joint, but then take a step back and look at the whole patient, the whole dog, because it might be that this dog's joint would be best treated with surgery, but if the dog has got a horrible heart condition, failing kidneys, it's really old, maybe putting it through a big surgery is not the best thing. And then the sort of final zoom out is also to look at the family as well and the dynamics of what you're going to suggest the dog goes through. How is that going to work with them? One thing is sometimes sort of, the financial side of things, but also the commitments. Are they going to be able to look after the dog through the treatment you're suggesting? And also for them to become engaged and understand that, yes, their dog has a problem. Perhaps there's not a cure for it, but there are lots of things that we can do to help. And sometimes it is this accumulation of marginal gains with lots of little things having a benefit over time can try to get us the best option for our dogs.
Perfect. Well, thank you very much for joining us today. And the conversation's been really interesting. Something that I will take away is that we have so many options available to us. And although that can feel overwhelming, involving clinicians and the owners in that conversation, as you say, we can widen out but also narrow down and make decisions that are right for our patients and the people who are looking after them. So again, thank you very much for joining us.
It's been a pleasure. Thanks.
Thanks for tuning in to the Nupsala Podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala Podcast. You can also watch on YouTube. If you'd like to stay up to date with all our latest content, please follow us on social media where we always post when a new episode launches. All the links and details are in the bio. Thank you.